Well, of course, these are different approaches because immunotherapy targets molecules on the surface of the myeloma cells and are more specific than other treatments. It's difficult to have an overall response because there are 4 types of immunotherapy. There are naked antibody targeting CD38, daratumumab and isatuximab, which are very active and are currently given in combination with standard treatments, both in young and elderly patients. Second are the antibody-drug conjugates, belantamab mafodotin, which is well tolerated as well, with a very special toxicity, which is a corneal toxicity. But the efficacy of this antibody is less important than the other 2 new immunotherapy, which are CAR T cells and bispecific. CAR T cells were the first to be introduced in multiple myeloma. They are extraordinarily active in relapse refractory multiple myeloma, and for instance, cilta-cel induce 98% response rate in heavily pretreated patients with 82% complete response. That is really unprecedented. The toxicity of CAR T cells is quite different. It's usually mostly cytokine release syndrome and neurotoxicity, but in multiple myeloma, these adverse events are frequent but usually mild and reversible. Finally, the bispecific antibody are almost as active as CAR T cells, probably 60 to 65% response rate in heavily pretreated patients, more than the antibody-drug conjugate, which is only 30%. The toxicity of bispecific is almost the same than CAR T cells, but less pronounced, and the severity of cytokine release syndrome and neurotoxicity is much milder than with CAR T cells. The specific problem with bispecific antibody is the incidence of infections, which can be severe and which can be seen even for the long-time treatment. Currently, the treatment of a newly diagnosed multiple myeloma uses only one type of immunotherapy, which is the anti-CD38 antibody. Both in elderly and young patients, the combination of daratumumab or isatuximab to the standard of care, Revlimid dexamethasone or Velcade Revlimid dexamethasone, does improve the CR rate, does improve the rate of minimal residual disease negativity at the level of 10 to the minus 5, and does improve the progression-free survival. So, is there a role for other immunotherapy like CAR T cell or bispecifics? It's not easy to answer this question because the results are so good with daratumumab or isatuximab that probably they will be used only in some specific indication. For instance, patients with very high-risk cytogenetic, or patients who don't respond well to daratumumab plus standard of care, or patients who relapse early. But maybe there could be an indication for consolidation and maintenance after autologous transplantation. Currently, and that's true for elderly patients as well, the treatment is very prolonged, which induce adverse events and which is expensive. So one question is whether, for instance, CAR T cells or bispecific could replace consolidation or maintenance therapy. both in elderly and younger patients after transplant. Well, I think that the most important challenge is that the result of current treatment is very good. So do we really need CAR T-cell or bispecific in patients who have such a good prognosis with standard treatment plus daratumumab or isatuximab? The challenges are high-risk patients for whom CAR T-cells or bispecific could be useful. And for instance, combination of bispecific could be useful in patients with a very severe disease like multiple myeloma with extramedullary disease. This is a very important challenge. Otherwise, as I said, the question is really to define which patients should benefit from this newer therapy, knowing that the results of the current treatment is so good, and it will be a balance of efficacy, toxicity, but also of cost. CAR T-cell in the Western countries are very expensive, but it's also a single shot. And the question will be to use bispecific for a limited period of time, trying to reduce the duration, the side effects, and the cost of prolonged therapy.